it, and give me a thumb sideways if you still have some questions. So we're going to do that because we really want to see if we have some areas of, oh, we have to do some more work. And so if you're giving us like a thumbs down or a thumb sideways, I'm going to ask you why. And so we can then address, and we probably won't get into all of the details, but we'll definitely make it so that we can follow up with you if we can't sort of figure that out in the moment. Chris, go ahead. We can't hear you. Okay, they're still trying to figure it out, I think.
Diana, you know how Zoom has like a thumbs up emoji?
Yeah.
But it doesn't have a thumbs down
Right.
emoji. So when you say that, do you want us to like do it?
That's why Colleen, I was asking, because there is no, which is a very positive thing that Zoom doesn't have a thumbs down emoji, but it may not be sort of reflect the real world. And it doesn't have a thumb sideways. So thanks for asking that, Colleen. But I would say, like, if you want to do the thumbs up, do it in your emoji. If, I'll be looking, and if for some reason I move on and I miss you, yell or put it in the chat, whatever, if because this is where we're spending the majority of our time today. We have a couple of other things we want to, we also have on the agenda to chat with you about and we've been talking to the steering committee about this, what it means for the collaborative to advise and assist in the implementation of and spread of VBP. So we want to talk about that. We also want to give you, and we will do this, an update on the targets, the VBP targets coming out of the VBP Compact Work Group. So that's what we're gonna do today. But we'll spend as much time as we need to on going through the model. Did anybody else join? Go ahead, Chris.
So can you hear us now?
Yes.
Oh, good. Okay. So
and there's no echo.
Great. Great. Yay. Okay.
Okay. We're all still figuring out hybrid meetings. They're hard to do, as many of you know. So do folks have any other questions as we move forward? Did anybody else join us since we did introductions? Any other collaborative members? Okay, and if we have folks, members of the public who want to make a comment, as I said at the top of the hour, please send me a chat and let me know that you have public comment to make. Okay, so with that, I'm going to turn it over to Michael. And Michael, when you're ready to sort of after each component, we'll see if there's questions, and then we'll sort of see yes, no, you could, or sideways could also mean I can't answer this right now, because we do know that some of you might say, well, I need more information. And again, what we're looking for is a temperature check, because when we come to you in July, we want to see if I don't want giant surprises in July. So I would like to know before July. I will also say, before we get lunch, we have been having conversations, one-on-ones with a number of you, both payers and providers, about, endorsing the model. And by endorsing the model, it means, we think this is a good model to get out there to facilitate spread and to promote alignment. We've been getting very positive feedback so far. So there's been so much work by the work group, and Michael's going to talk a little bit about that now. So I will turn it over to Michael, and we'll go from there. Michael, you're on mute.
Okay, am I muted?
Yep. You're good.
Right. I can't see all of you while I'm displaying the presentation. So Diana, if you could be my eyes.
I'm on it. Absolutely.
All right. Nice to be with all of you today. I'm going to provide an overview of all of the work that this hardworking work group has accomplished. My colleague Alyssa and I have presented you with updates before. So some of this content you have seen before, and there's a little bit that's new. What's really different is I'm going to pause, as Diana said, after each major component so that Diana can ask you all to weigh in. So let me proceed. So I'm going to provide a high-level description of the process and what we've accomplished. Then I'm going to walk you through the primary care VBP model, and with a sort of a one slide, here's an overview of what it is. And then I'm going to walk you through 12 different design decisions that have been discussed or are being discussed in a couple of cases with the work group. And I'll highlight what are the remaining topics at the end that we still need to address, which there are a few. So about the work group, it's met 12 times since May of last year, which is a lot of meetings. We have accomplished a lot in that time period. This is not easy work to do. It's hard to find a disparate group of people that come to agreement on a design for a payment model, but we've done pretty well in doing so. Specifically, we developed a work plan focused on 12 key topics and design decisions. We agreed upon principles to guide payment model design. We then worked through a set of questions on specific design decisions to help frame our VBP payment model. We settled on draft recommendations using a consensus-based approach in almost all cases. There were a few design decisions where we didn't reach 100% agreement, but in almost all cases we did. I should note that if you have a work group with a lot of people on it that's meeting for a year, you are not going to have the same people attend every meeting. And so that gets reflected in the recommendations. That we don't really have the exact same work group meeting each month. So while we had some stalwart attendees like Deborah and Dawn, there were other people who were there for many. There were some people who just were there for a few of them. So that's just the nature of this work group. And so I want to mention that at the outset. Completion of the design is scheduled for late spring. Given that we are now in early spring, that means we're getting close. So the design decision topics, the 12 that I referenced, are listed here. The 3 bold items are new. So the last time we reported to you on this work in January, we had not talked about those 3. We since have done so and incorporated them into the model. So my quick one-slide summary of this all-payer primary care payment model is that it has 3 primary component pieces: prospective payments or capitated payments for a defined set of primary care services. 2, it has infrastructure payments that includes a base payment tied to PCPCH tier, and then potentially additional payments for specific high-value services. And then 3, there are performance-based incentive payments that are based on an aligned quality measure set to be developed that's specific to primary care. And then all other payments will be fee-for-service for other covered services, really covered services not covered by the prospective payment, right? So this is the one-slide overview of what the primary care payment model is. It really follows from the 2018 recommendation for a payment model. So I would say we took that 2018 recommendation and we built it out. So I'm now going to walk you through those 12 design decisions, and after each one I'm going to pause and Diana will ask you to reflect on whether you support the group's recommendation. Okay, so base payment model, as I said, follows from the 2018 recommendation. It was designed at that time to align with CMS's then CPC Plus model. So risk-adjusted advanced infrastructure payments, performance-based incentive payments, fee-for-service payments for what's not covered by prospective payments, and then prospective payments for a defined set of services. We'll note that we've had conversation about potentially pursuing a second primary care and behavioral health integration payment model. The work group felt that we shouldn't have two payment models, we should have one. And so behavioral health integration should be integrated into the above model. I want to note that at our next meeting, we're going to revisit how most effectively to integrate behavioral health integration and total cost of care into the payment model based on feedback that we've received from work group participants. But the key takeaway is that behavioral health will be integrated into one primary care payment model rather than have a second payment model for primary care and behavioral health integration. And then, as I said, we're going to talk about total cost of care at the work group's next meeting. The current recommendation is to allow for total cost of care designs to complement the primary care VBP model, but not to make it part of the primary care model. We've received feedback from some health plans. They feel strongly that total cost of care should be integrated more formally into the primary care model. So we're going to talk about that we're going to talk about it anew at our next work group meeting. Okay, so this is the core or the base payment model. And so it's appropriate to start here because we're talking about a VBP payment model. Before I move on to the 11 other design decisions, I'm going to pause here and Diana, invite you to work your group process magic.
Yeah, so any questions for Michael? And knowing that the total, like there are two pieces here that are like we don't have a firm recommendation on yet. The behavioral health integration, it's going to come into the model, but we don't have the details there. But and also total cost of care, the group is deciding it. So, oh, I see Deborah. Okay, hold on, Deborah, one sec. So given what you know about what the group has recommended, let me see, and Deborah, I'll come to your comment in a second. Let me see a thumbs up, a thumbs down, or a thumbs sideways. And if you want to, if it's your thumbs up, you can use your cute emoji. Let's see, okay. Okay. I'm seeing some folks not doing anything, so I need to find out why. Okay. Okay. All right, so I see Deborah, Dawn, Bill, Colleen, Liz. I think Danielle probably can't do it. So from those of you who gave me no indication whether this was a thumbs up, I see Christy. Okay. Please chime in. Okay, I'm seeing lots of thumbs up. Okay, so if you did not weigh in here, okay, good. I see Deborah, Bill, and Colleen not weighing in. Janine. Deborah, go ahead.
I asked my question because I have caveats that those 4 design pieces, I have questions or considerations within those. So overall, I think it's okay, but there's nuances within those 4 bullet points that I would like to call out. So that's why I was asking about the appropriate time to speak to them.
And so, Michael, we're going to get to some of those details in the other design elements. Is that correct? Yes. Yep. So how about when we get there?
Yeah.
Dawn. Oh, no, you gave me a thumbs up. I saw it. Colleen.
It's the same thing. It's kind of the nuances of those subparts. Yep.
Yes. Yeah. And okay. Bill, did you give me a thumbs up and I missed it?
Yeah.
Okay.
I did give a thumbs up, but they're not staying up for very long.
I know. So that's the issue. So you know what? Danielle and others have had a great idea. Put it in the chat. And you can even type thumbs up, thumbs down. We will be able to capture the chat. So yes, they go away. Others, Janine, I didn't see you. Maybe, was there anybody who didn't give me a thumbs up other than Colleen and Deborah? Because they have questions. So you have questions on some of the details. All right. Okay. Go for it. Move forward, please, Michael.
Okay. So design decision recommendation number 2 is about which primary care practices should participate in this payment model. We had early process conversation about PCPCH recognition and whether it should be incentivized or a prerequisite. We had some differences of opinion on this. Ultimately, we settled on that there should be a strong recommendation for praxis to become certified, but not a requirement. I don't think we had 100% consensus on this, I'll note. And that payers should incentivize and reward certification through supplemental payments. And that's something that I'll talk about in a little bit more detail. Otherwise, no practice participation prerequisites, no minimum practice size, no other performance pre-qualifications. And the introduction of primary care practices to the new payment model may be phased in. So this is really left to payers and practices to work out, but with the idea that there would be a 3-year transition, and how that transition occurs would be left to payers and practices.
Okay. Michael, this is because we're moving on to a third design element next.
Yep, this is it.
Yeah, this was a lot of conversation amongst the work group. So here's what are there any questions about this? And again, we went through some of these design elements when we last met, so there may not be questions, but I want to pause. So then here's please give a thumbs up in the chat. If you're a thumbs down or sideways, raise your hand. Okay, I see Liz with her hand up. Okay, I see you, Linnea, all good. All right, so that's what we're gonna do. If you have concerns, I'm gonna ask for hands going up. So Liz, go for it.
Yeah, thanks. Hi, everybody. I had a conversation a little earlier today about this, but my understanding and my memory of our conversation was that just a slight nuance that the phase-in period wasn't for practices to buy into the VBP model. Like, I think that will happen, like the in and the out of practices is likely to happen over time. Practices will have varying readiness to adopt the VBP model, and new practices will exist, and some practices will cease to exist. And I think there will be a continual entry and exit from this VBP model by practices. So that to me wasn't the phase-in period. The phase-in period was PCPCH is not required to enter, but the phase-in is expected to happen over the first 3 years with VBP. And so by the end of being in the VBP model, you would be a certified PCPCH. So to me, that third dash, the phase-in period for practices, should be a third dot under the first dash. So you don't have to start with PCPCP certification, but within 3 years of practicing within a VBP model, you should get there.
Thanks, Liz. So I'm going to ask folks, because I don't recall, is that, and we can bring this back to the work group, but does anybody else, this is Brian's recollection as well. Okay. And I see Colleen nodding her head. Do others? Okay. So we'll add that back in if that was what folks are remembering, and we'll just bring it to the work group for a double check. I also see that Bill has a question, and Amy, maybe you can help us with this. Do we have an estimate of how many practices are not engaged at PCPCH at this time?
Yeah, that's a good question. So there are 638 as of today PCPCHs, and we estimate that there are around 800 or so primary care practices that are eligible to participate in the program. Unfortunately, there is no good list of practices, as I'm sure others on this call know, but that's our best estimate based on what we've kind of cobbled together over the years based on various lists. So most. So
I knew you'd have the answer. It's nice when you think great. Any other comments on this before we go to the next one? This is exactly the kind of conversation we want to be having, so really appreciate it. Go forward, Michael.
Okay. So our third design decision was which primary care services to include in the prospective payments. The work group adopted guiding principles for both inclusion and exclusion. I'm not going to read them. You can see them here. Over the course of a few meetings, there was agreement on a specific set of services associated with CPT codes. This is no small accomplishment to get agreement on this. And we did so in relatively short order, given the challenge of the task. I'm not planning on reviewing the code list for you. It is in the appendix of this presentation. So in the presentation that you received, I think in advance of the meeting, you can look that up. But the focus was not on specific provider types, but on services that are provided by a diverse array of care team members. And the recommendations were informed by an analysis of APAC claims data that told us how much historical spending was associated with the different services. And for those of you who didn't participate in the process, the vast majority of primary care spending is associated with very few CPT codes. Even though there are zillions of codes, many of them are associated with very little spending. And so the codes that were included do represent the great majority of primary care spending historically. That's billed with CPT codes. And that's it.
Questions on this? This was, as Michael said, over at least a couple of meetings. And I think you've seen this before. Any questions? Okay, so then if you give me a thumbs up, either in your box with your hand in the chat, and if you have concerns, please raise your hand. So first we have a question from Carolyn. Do the CPT codes include behavioral health codes, Michael? I don't think so.
I should know. It's been so many months since we worked on this that I actually don't remember the codes anymore.
Yep.
So
I don't think I don't recall. Deborah, do you recall, or do you have a question? Because I have Liz with a question.
I have a question. I don't believe that they were the codes that were included were the
Right.
preventive medicine counseling codes, but that's not necessary. But those are the 99401s, not the, I don't think there were health and behavior codes nor mental health codes.
So Colleen looks very certain of this, that they were not, and they're in the appendix.
yeah, I'm looking at them now.
They're not.
No, there
Okay.
are no mental health service codes.
Okay, so, and Dawn, totally see you in the chat. I want to review the code list. Please, I'd urge all of you to do that. Again, taking a temperature check. So make sure you do that. So Liz, you have a question or comment?
Yeah, it's slides 27 and 28 if people want to look it up.
Yeah, so generally this is spot on. I think the other thing that I remember us talking about during those couple of really intense meetings, really the included services are the services needed across the populations on a regular basis. But the piece that I don't see included sort of in bucket 2 are the services that are not universally required. And not sort of continually required. So the episodic versus the sort of subscription model services. So things like obstetric care. Obstetric care is, I would say, pretty standard across family medicine practices. So not all providers do it. And even if all the providers do obstetric care, not all your patients need obstetric care. And even stratifying by age and gender isn't necessarily going to get down to that sort of episodic who needs it and who doesn't. So I think making sure that nuance is included in the exclusion criteria. And then I did have a chance to review the codes, which look great, but I Also think it would be helpful for us to give an exemplary list, so some examples of, not a comprehensive list of things that we recommended being excluded. So possibly things like obstetric care, advanced care planning, in-home care. So the things we want to incentivize because of the impact it'll have on reducing cost of care.
Great, Liz. I think that idea of providing some examples is good and actually goes to Bill's question. Deborah, do you still have a question? Okay, so let's go to Deborah and then we'll go to Bill's question.
I guess questions or concerns, or where I can't do a full thumbs up, I guess, so far. I agree that these are the lists and the guiding principles are really important. I have a challenge with the prospective capitated payments on on an attributed population. So our group continues to have and so this leads into the attribution perhaps, but we have a challenge when it's attributed and don't believe that it will appropriately capture the population throughout the duration of the year. So that's where my hangup is, and I'm not sure how I can resolve that. And then concern number 2 is that some of the codes that are included aren't currently valued or paid by health insurance companies. And so that goes into the rate calculation of how the rates are valued. So for example, care management codes aren't consistently paid, or after hours codes, or some of those things that are really important to have in capitated payments. So again, that dribbles into the rate, how the rates are created, but links into the codes that are included in this, because if there's an expectation there provided, they need to be valued appropriately.
Thanks, Deborah. All right, we'll bring that piece back. So Michael, we have a question from Bill about explaining the second bullet in number 2 a little bit more. Could you do that? How we got there?
Yeah, I think the feeling of the work group when these were developed was that if there are services for which we want to motivate increased volume, then we should not put them in the primary care prospective payment. It's just, I mean, I don't know how to say it other than that. If you want to drive volume, leave something in fee for service. I don't actually know if there were specific, I don't remember because it's been so long since we talked about this. I don't remember if there were specific codes where we said, this is one where we want to incentivize volume, so let's leave it out. I simply don't remember at this point, but that's what the concept was.
Michael, I think we did. And I think
Okay.
several of those codes, like after hours access and some of the immunizations and some of those things that
Yeah.
we really
Oh, you're right.
felt
You're
like,
right. Thank you.
Yeah.
Thank you. Your memory's better than mine.
Oh, I don't know about
also
that,
talked-
but
We also talked specifically about home care. I think we had some conversations about sort of what that could do to impact cost of care, and there was a patient example. And so
Mhm.
yeah, we definitely had a conversation about some specific exclude. Yeah.
Great. That's why we have lots of folks who've been working on this.
You can, you guys can all see why I'm never going to write an autobiography, because I won't remember anything from my own life. So thank you for your memories.
All right, thanks, Bill, for the question. That's exactly the kind of question, and really appreciate these comments. Okay, so got some of the concerns that folks have, and unless there are any more, let's move on to the 4th.
Okay, so number 4 touches upon Deborah's concern regarding attribution. The work group looked at the attribution principles that the report in 2018 communicated, and those principles were intended not to require that attribution be the same, but that there be voluntary alignment, and that there also be transparency in methodology. And so after revisiting those attribution principles, there were no recommended changes to them. and really amplifying the principles, the work group members felt that payers should share their attribution rosters and maintain a process for addressing incorrect assignments. Deborah, if you want to talk about your problems with attribution further, this would be a good time to talk about it. But I would say that the work group largely affirmed that report that was published in 2019, but was really a 2018 report.
Let's go to Deborah and then Colleen. Go ahead, Deborah.
I think that in general, so the attribution principles being aligned makes sense. Our providers, as we really start, and folks that have really been heavily involved with managing a panel, really get stuck on the attribution versus assigned or chosen, and really talked about it as a make or break to supporting the capitated component, because there is the potential for the rates not reflecting the full year's worth of services when patients come in for a service. So if a patient's not assigned or attributed until mid-year, it's really challenging for the practices to make up that revenue volume. And so so the attribution process and the correction is a must, but making the practices whole for when they're attributed, if it's done mid-year, is really critical to this process. And preferred is assigned. And I think we have a lot of work to do in educating providers as well as patients and employer groups as to why selecting a primary care provider is not an option, because I continue to bump into that concern. And I know we've talked about it in this group, and I'm not trying to resurface old discussions, but when I came back to my group, this was a really critical area that I'm still trying to process and work through to figure out the solution.
That's what I was going to ask you, Deborah, if you had a suggested modification to the recommendations, or do you want to wait to bring that to the work group?
No, I mean, the proposed modification is, why in the world can't payers require assignment? Because if we're held accountable to a patient having certain actions, the patients need to know and be a part of the solution. And I know that we've discussed that. And so I'm trying to figure out if there's any in between.
Yeah, okay, I hear you.
Yeah.
Does anybody have I see Colleen and Bill, does either one of you have a direct response to Deborah you want to share? If not, we'll just go in order of Colleen and Bill. Bill, do you?
I just have to confess, I am not following what Deborah's concern is at all.
So Deborah, you want to try again?
I don't want to hold up this
No,
conversation.
it's okay. We got some time. We have a couple more minutes and we can come back to it. But why don't you just try one more time?
If patients are changing plans, which may happen frequently as premiums, are increased. So let's say they move from one plan to another. There's not the claims history to show that patient has been going to a provider. The patient, so the plan doesn't have the information that they've seen this provider. The patient doesn't come in until their well visit in September. So in an attributed population, the patient wouldn't be assigned to the provider until probably October, and if we're lucky. So that's 9 months worth of services that the provider did not receive per member per month payments. And so in a fee-for-service world, they would have been paid for that service. In a capitated world, they would only be paid a third of that or a quarter of that service. So in an attributed population, and I know it may or may not be a large number, but they have a hard time. They're challenged if it doesn't go retrospective in terms of making the provider whole for those services. Does that make sense?
Bill, does that help?
I now understand what Deborah is saying. I just I mean, and now I feel like we can move on. I actually don't think that the way we would calculate payments, that would be an issue at all. It would be a non-issue. I think that the way that we calculate payments, it just would completely render that point moot. But Deborah and I can talk offline about that.
Okay, thanks, Bill. All right, so Deborah, we captured that. Colleen, go ahead.
I just wanted to say that I don't not agree with these, with our principles. When I was filling out the survey previous to this, I think what's hard is like, it looks like these 12 are independent, but actually attribution has a big role in all the other ones, right? Like, depending upon how it's this. So they're not all equal. And this one is like, we strongly recommend. And that the trick is that like, we are very far off from the recommendation. So when I filled out the survey, I was like, I still agree. It is like, we are very far off from what is outlined in there. And so if payers just share and they're like at this part of the recommendations of attribution versus this part, the ripple effect to the other parts, particularly in controlling cost, will be big, because the people that fall out are some of the people that are most likely to have some of the high cost events. And that's partially why private payers are like, it's not penciling out. And so it's like a yin and a yang that I'm like trying to like emphasize from an upper level, because it has like a lot of it has an impact on metric, then what's your denominator for the metric. It has an impact on, what is that population like Deborah was talking about for capitated payment, and then who gets the population that falls out is actually, I think, one of the most important ones that then just keeps getting scoped out. So I just wanted to note that, because it looks linear, but I'm not sure that it is linear.
So Colleen, really appreciate that. And we're doing it this way to sort of temperature check. And I think there's no disagreement that this is a whole package, right? We're not going to say do this one, but don't do these other 5. And I just want to clarify what I heard you say, because it took me a moment. But what you're saying is the current state of affairs is far from the aspiration. Is that what you were saying when you said
and I think, I think for some of us, we did come up with a package that largely wasn't implemented. And so
Right.
we're coming up with this next package that's actually bigger and saying, you can't do it individually. And I'm like, I don't know, is insanity doing the same thing over and over again? Like, are we just coming up with this big package? And so later on, when you asked us in the survey, like certain parts, I guess I would say there are some parts that if they're not done, the rest of the parts don't work well.
That's super.
And so I just wanted to highlight that, because I'm actually flabbergasted by how far we are on this attribution piece for a number of valid reasons, actually.
Yes, and I've shared that I've actually had nightmares about attribution. It's a sad state about what's on my mind, but it's a tough one. We've been working on it for a long time. Okay, anything else on this? Bill, you still have your hands up. I assume that was from earlier, but let me check with you.
Oh, yeah, it was from earlier, but as long as
Go for it.
I have to confess, I actually don't understand that concern either. I mean, I run MODA's member attribution process. I'm not really following what the concern is.
Colleen, do you want to, I won't speak for you, Colleen, go ahead.
I don't know how, I haven't looked up MODA private side, Bill, but like, in working with a large number of systems across the state, there are many who are not they're attributing and assigning. And some of those people, bunch of kids born at OHSU, so they're assigned to OHSU. They've never actually been to OHSU clinic. And so then people want to take the money to be able to like invest in the service, but then they actually don't see them. So then they bump them out. So the very people that get bumped out of the denominator are some of the most socially complex. So then when people are wondering why we're not reducing costs, it's because from an attribution issue, these people keep going into the silos and dumping out. Another system I know, I'm looking at their PCPC attribution. They're assigned there are kids birth to 5 assigned to an urgent care clinic. And I'm like, what? And that they look like they've attributed everybody to a site. And I'm like, I don't think an urgent care clinic is a good place to attribute a birth to 5, but that's because that's where that kid went. It is highly problematic to me that there is some kid out there that is attributed to an urgent care clinic, but our systems. And so some of like Deborah's sites, they're going to be like, I know you attributed to them. I tried to get them in. I can't, they're out. And when you talk to payers about like, what are we going to do about all those people who keep getting bumped out because the practice tried, you attributed them. But they're off the radar. When you look at some of the data around people who are off the radar, the 25%, I'm just talking kids who all have clinical recommendations to be in. When we look at the data on the 25% of kids who haven't gone anywhere, majority of them have been attributed somebody where. And then in the practice level, like not my patient, we're bumping out some of the people who actually cost the most money. So we're trying to invest in primary care to quote control costs, but there's a really group of vulnerable people that keep getting bumped out. From either from the practice saying, I know you attributed to them, they're not me, or vice versa from the system needing, you're on the hook to attribute, and whether that gets adjudicated, if that makes sense.
Okay, that's super helpful. I mean, I don't think we have those problems at MODA, but I can imagine that somebody who is not very organized about how they do it would have those problems.
Great. Thanks, Colleen. Thanks, Bill. Okay.
Ready to move on?
Yep.
Okay. So design decision number 5 is how to develop the rates for the prospective payments. And here, the work group supported developing the rates using a set of guidelines. So essentially, it's a range of choices that would give flexibility for both practices and payers to reflect practices of different sizes and types. So for larger provider organizations, payers and providers could agree to develop practice-specific rates on a case-by-case basis, or utilize a standard capitation rate using market-wide data. For smaller providers, there could be a standard capitation rate on market-wide, or maybe a small practice-only cohort. And then for practices with what we call here special patient profiles, the payers could develop PMPM capitation rates specific to practices of that type. So based on patient cohort. Right, so this is, for some of these design decisions, the model is more prescriptive. In this one, I'd say it's less prescriptive. It allows for a range of standard models and customized models for both practices with special patient profiles or of very large size, or a practice type.
Scott.
Oh, I'm sorry, one other
Oh, so
thing.
you're not done. No, okay. I didn't know if you, so you go ahead and finish and then we'll go to
Yeah,
Scott.
one other thing. The work group acknowledged limitations of developing payment rates based on historical spending because it only includes services that are traditionally covered and paid for. And I think maybe Deborah made a point about this. So that's just, it's an intrinsic limitation of such an approach.
And why don't you go to the next slide, actually, Michael, too, because I don't know if Scott's question will be
Yeah.
answered. I think there's
Yeah,
another.
okay. So more on this. For services that are delivered outside of the capitation rate, payers should reattribute on a monthly basis to shift prospective payments to a new site as quickly as possible, because patients do change their care seeking patterns, as we know. And payers should monitor the percentage of services, primary care services, I should say, that are delivered to attributed members outside of the practice, and where the percentages are particularly high relative to other practices, inquire of those practices what might be happening. And the work group recommended that rates be updated annually and that payers provide a general description of the methodologies to providers using a common template that OHA would develop. So that in 2 slides is the recommendation for the rate development methodology.
Scott,
Can you go back to the previous slide, please?
Sure.
Thanks. I am really, really worried about this. I appreciate the risks that have already been raised in regards to historic, and I agree with those. I also see the next 3 bullets as basically, I'll say, practice payer negotiations in which the practices are at a tremendous disadvantage, even if they're larger. I mean, large system clinics that are, I'll say, hospital-based practices, shall we say, may have an advantage. And the smaller providers or even large independent providers are really at risk under what's said here, in my opinion. And I would much rather see that we had criteria that were not related to the size of the practice, but rather to the complexity of the patient population. I mean, that's how you define, I'll say, expense, is by the patient, not by the practice, in my opinion. So I think this is a big risk area. I don't know that we're sophisticated enough to do what I just said. So I'm open to this, maybe the best we could do, because I think, you know, the need to move in this direction is real, and I'm not trying to stop it, but I am saying that this is really concerning to me. The other thing that I would say, if you go to the next slide, where it's annual updating, is 2 things. Number one, it creates for increased uncertainty. A year is a really small period of time, and if it's renegotiated every year, as you're trying to do budgets and make decisions, a year is short. And that's number one. And number two, if I don't like the negotiation part the first time around, I certainly don't like the concept that we have to renegotiate every single year. So it's problematic for my thinking about this. So those are my comments. I'll leave it at that for now. See if anybody else agrees or disagrees.
let me hear, Colleen or Melissa, did you have something specific to what Scott said or something separate?
I have something specific.
Go ahead, Melissa, and then we'll go to Colleen. Go ahead.
I think I agree with everything Scott said. I think that, practices are really impacted by the types of members they receive. So definitely needs to be more risk-based and geography-based, as there's complications in, rural access to care and how do they even get there. And there's just more at play there for providers and clinics. The other thing I would say about the annual negotiation, practices are evaluated annually, but going through a full negotiation again is really administratively burdensome on the payer and the provider side. So that's why I would agree.
Thank you. Carolyn, I see your comment in the chat. Okay, this is good feedback. All right, so I'm gonna go, anything else on that topic before I go to Colleen? I gotcha. Okay, go ahead, Colleen.
I guess just to kind of play this out, but Michael, your brain's so smart. Chris DeMars, you've thought a lot about this. I need help. So we're trying to make sure that the part about it that's difficult, right, is you want to make sure that the rate at we're talking about PCPCHs who are attesting to things. And so we want to make sure that the rate covers the kinds of things in a PCPCH that are needed. And what we all know is like a tier, in concept, more points, question mark, is more things. And some of those things aren't billable. And so that's one part of what we're trying to do, right? And then the other part that we're trying to do, because it actually has such a dramatic impact in actually setting up primary care to do the right thing, particularly as we think about payment to address root causes of cost, is that what it takes to have those services for certain populations is more. And a lot of the what it takes is unbillable. So for example, one population I brought up was children with special health care needs, for which this model was originally developed. And currently I know of no payer that is doing enhanced payment for the model that it was originally developed for. And yet, if you were a practice who had a high children with special health care needs population, that you're doing referral management, care plans, care coordination, all these things that are unbillable. That is what I'm understanding from a rate methodology, Michael, we're trying to make sure is taken into account, which even if you did a back, you wouldn't really capture that, partially because of some of the other components of this payment model are to get to the payment so that you can make that retro. The other is we're trying to design from an equity forward point of view, a system that meets the needs of the patients it serves. And so some of the reasons, and Chris, we found this in Inc., is when we thought about like the most socially complex people and trying to make sure that we were giving higher rates to practices that see a highly socially complex population that's gonna need potentially integrated behavioral health, that's gonna need potentially to invest in a peer-to-peer supporter that they may not get paid for. The issue is because our system was so not designed well for those populations, they didn't access services. So if you looked back, it was like, we actually need the front end rate to support the actual future services that they'll collect. So Michael, what I'm struggling with is, I know you've heard this, I've read your papers, you know about this, but this is where I'm really struggling with how to Scott's part, I still don't see it. And I maybe because you're like, no, I do see it, and or no, there's not a model for it and we need to call that out. But like, I am agreeing with, like, we're trying to do both. We're trying to make sure the practices have this base payment, and we actually have to acknowledge that what it takes for certain populations is a lot more. And the problem is looking back doesn't give you that good opportunity, because those are the very people that our system isn't working well for. So tell me, can you help me connect the dots? Because I know you know this better than anybody. And Chris, I know you guys have resonated, because how do you do an increased rate for somebody who had no look back rate because our system was so terrible for them? So I really would love to learn, because I know we share the intent, but in terms of the solution to offer, I'm still struggling with if I could give a thumb up on this, because I'm sharing the same concern with Scott and others about the population part.
Yeah, I think your points, Colleen, are all fair. So what we have not done within the work group in developing the rate development methodology is to develop a cost-based rate method. Okay, a cost-based rate method would say, okay, so what would it cost a PCPCH to deliver all of the services that it's supposed to deliver? And then let's set a rate based on what those costs would be. I did an exercise like this several years ago with Ed Wagner to think about, what's a cost-based model for primary care practice that's delivering continuous, comprehensive, high-quality care. We didn't do that here. So how do you solve for the fact that the current payment model may not compensate for everything a PCPCH should be doing. I think the only way that that can be done, aside from doing a cost-based model, which could be done, not easily, and we certainly didn't do it here, would be to address those PCPCH attributes through what we've called infrastructure payments. And we've
Okay.
identified specific care and population characteristics for which a supplemental payment might be appropriate. I think that's probably the best and easy way to do it, as opposed to trying to build it up from cost. And I'll note that building it from cost, aside from being just complex and arduous, is also challenging when not all practices deliver the same services,
I know.
and never will all be delivering the same services. So I like having the flexibility to have supplemental infrastructure payments for practices that serve different types of populations than to try to come up with one fits all sizes payment model.
Got it.
So that's
Okay.
just my personal opinion, Colleen. That does not reflect the deliberations of the work group, and I want to make that clear.
Yeah, I just think what Scott said, it resonated for me as a work person who attended a lot of those meetings. That was some tension, Scott, we were feeling on some of these parts. And I just want to know, it's particularly problematic for pediatric populations because Medicare well visit rates are so low compared to Medicare or private. So it just compounds this issue that's really.
Yeah, and we didn't address
for the
adequacy
population
of
we're
payment
talking about.
levels.
And Oregon has expansive, so it gets really complicated. But I would
Yeah.
love to, Chris, you had your hands up, I'm sure. and
I'll note the other thing that Scott said was that there's a power differential between payers and practices, particularly smaller ones. And Scott, you didn't call for, the weight of the state coming down in support of practices, but currently, the way that rates are set, if not negotiated, they're set by payers. And for small practices, there's more power with payers than there are with some small practices. We didn't address that underlying market dynamic. And frankly, nor do I think that we should have. That seems a little out of scope. But these broad issues about adequacy of base level payment are much broader issues than what this work group was tasked to do.
Thanks, Michael. Chris, did you have a direct response too? Because I know Colleen had asked you to chime in. And you're on mute.
Okay, can you hear me now?
Yes.
Okay. In addition to the PMPM, which I completely agree with, the idea of social risk adjustment can help get to this as well. And just a heads up that we will be putting out a call to for volunteers to participate in a social risk adjustment work group as part of the model development work group in a meeting or two. So maybe if and when this makes it into the recommendations, we could kind of add that, kind of a placeholder for the social risk adjustment to be added in the future, and also mention the PMPM here.
Thanks, Chris. And Melissa, I know you had your hand up and you put it in the chat. Was that what you wanted to share?
Yep, just adding a few more specifics that I'm particularly aware of. We have a clinic that, you can bill for interpreter services off of your medical claim, but, all those outreach, calls and attempts to navigate care are not really covered in the same way. And the same thing with CHWs in the clinic. And then how do we even track those? How do primary care practices track those services? So, thanks.
All right. Anybody else on this?
Yeah, Diana, thanks for giving me a chance. I it feels important to have the conversations we don't have. I guess Michael, really appreciate your insight and expertise in saying that, you know, hey, this 4-bucket model with infrastructure payments is likely taking the place of sort of doing a cost-based VBP. But I don't remember talking about that. You know, certainly I don't know that I've ever conceptually thought about a cost-based VBP prior to sort of the last 10 minutes. So I don't feel like we've talked about that. I don't think we've talked about how do we make sure that the power differential is equalized as we move into this VBP model, and those feel like important concepts. So appreciate the conversation. I sort of was putting my hand up and down because I don't know, like certainly it's not pertinent to, you know, number 5 here, but I think it is pertinent to this group. And I think those are discussions we should have.
That's great. Really appreciate that, Liz. And I don't recall either, but we can bring these concerns back to the work group, which is sort of what's happening here as we have these conversations. We're noting these concerns and we'll see, you know, what we can do with them. So thanks, Liz. And on the power differential piece, I feel like that's come into some of our conversations, but maybe not as explicitly as it might. I see Dawn's hand.
Yeah, just really quick. I do think that one of our attempts to address this is in the disclosure requirement, right? That the health plans all disclose what their rate methodology is, and that the template developed by OHA will allow apples to apples comparison so that practices are informed about that. So I feel like that is one mechanism to try to address some of this.
Great, Dawn. Appreciate that comment. Anybody else on this? So if we haven't heard from you, assuming you're good with this, but we've captured the concerns that folks have raised. Scott, Liz, others in the chat. Deborah.
I don't think that I have anything that hasn't been said or isn't on the list. And so I just wanted to affirm that it really needs to have pediatrics or that 0 to 18 population considered separately. And the rates must reflect the value of services included in that was included in the capitation codes, but not adequately or consistently paid. So those were already discussed, not trying to rehash, but just emphasizing those points.
All good. All right, we're going to move on. Michael.
All right, next one might be a little easier. Might. And this is how to account for cost sharing and rate development. We didn't spend a lot of time on this. It was a pretty quickly resolved question. The recommendation was that the capitated amounts be based on the anticipated paid amount rather than the allowed amount. So for those of you not familiar with the term, this is insurance ease. Allowed amounts are a combination of what the health plan is going to pay and what is the member's out-of-pocket obligation. Those out-of-pocket obligations in general are larger for commercial plans than for Medicaid. And there was agreement that the payment amount should be based on the paid amount, which is the health plan's share, and does not include the member share. And that's it for this slide. So
any concerns with this? That's what I've sort of moved from thumbs up, which was fun, but it was too hard. So any concerns? Okay, thanks, Deborah. See that. All right, so sounds like we have agreement on this.
Okay, next topic is more complicated, and it is value incentives and rewards. So everything we talked about so far has really been focused on the parameters for the prospective payment. So now we're going to talk about the performance incentive payment. And so I've got 2 slides of recommendations here. And I'll note that there was not 100% agreement on all of these elements. So first, practices should be rewarded for both high performance relative to external benchmarks and for improvement over time. There was one health plan that said, we don't believe in rewarding improvement. We only want to reward high performance against benchmarks. So we did not have complete agreement on this. So a little bit more detail. The external benchmarks could be HEDIS benchmarks, statewide CCO benchmarks for Medicaid, or other statewide insurer-specific network benchmarks in the event that there are no HEDIS or statewide CCO benchmarks, or they're not applicable. Improvement should be weighted at the same level at high performances, so that practices have a strong economic incentive to improve, and specifically practices with lower performance scores. They're going to see a significant reward that will help justify an investment in committing to improvement. Improvement targets should be both meaningful and they should be reasonably attainable. So meaningful, I think, speaks to some measure of statistical evaluation, and reasonably attainable means that the stretch isn't so far away that a practice would say it's not worth me trying because I'm never going to get there. Practices that have been identified, that are identified as having unusually high medical and or social risk should be held accountable only for improvement if there's agreement by the payer and practice that the external benchmarks aren't applicable. And I would say really aren't reasonable. And measures for which there have been substantial specification changes should be temporarily removed from the incentive methodology until there are new both external benchmark and practice specific data available that reflect the new specifications. All right, so this is slide 1 of 2. The next slide speaks to the dollar value of the incentive payments. The work group agreed that they should equal at least 10% of the value of total projected practice service payments. So that would go with capitated fee for service for the attributed patients. That doesn't mean that there's a guarantee that the practice is going to get incentive payments worth 10%, but that should be at least the amount that they could earn if they met all of the incentive metrics for achievement and or improvement. And if there are payers whose current incentive models are below 10%, then they should be allowed to transition to 10% over 3 years. And again, 10% was a floor, not a ceiling. Couple of other recommendations related to incentives and rewards. Incentive payments should be made as proximate to the practice's actions to achieve rewards as soon as possible. We did not have full agreement on this. This idea of making the payments timely was discussed at some length, and some felt that that this was problematic. I think the reason this was discussed is because sometimes reward payments can be made a year and a half after the performance year, which is a long way away from the activity. So ultimately, we had a compromise with this general language to be as proximate to the actions as possible. And then last, incentives should be tied to a common set of performance measures used by both commercial and Medicaid payers, with flexibility for limited use of Medicaid specific measures by CCOs. And I'll note that design decision number 8 is all about the aligned quality metrics. So my recommendation is we don't talk about that now because we have a whole separate recommendation that's about the aligned quality metrics. So Diana, I'm going to stop there.
Let's see first if folks have questions for clarification. All right. So this was a lot of conversation and compromise on this. I recall that. Do folks have concerns or concerns? We already just said questions, concerns. Okay. So maybe our
Diane, this is Bill Bushcott.
Go, Bill.
I just curious about, I'm sorry if I missed it, about the 10%. The 10% number and sort of what was magical about that number.
Michael?
Yeah, so I think, Bill, that's actually an idea that we introduced it to the work group. And it's based on some old research, I think, by an economist at Harvard, Meredith Rosenthal, on thresholds for which incentives needed to be for incentives to be meaningful as a motivator for physician organizations.
Thanks, Michael. Folks good with this one? Anybody have concerns? Colleen.
I'm just going to give one example of how this ties to the other. One of our attribution frameworks is only assign somebody if they've had a preventive visit at that site. So then you're tying metrics, denominator attribution, and you're picking a parsimonious set. If you look at what people are considering, again, because these metrics were often designed for a health plan unit of analysis, that you're benchmarking a health plan, not a practice. If you require them to have had a preventive visit in order to count them fairly to attribution, the attribution algorithm actually impacts the numerator. Does that make sense? So like 3 to 6 well visit measure for a child 3 to 6, if you look at it's not a well visit, it's an established patient, like it's a preventive medicine visit. So that's an example of what I'm talking about, how like, as somebody who has developed metrics that are in national sets, and then people say we just modify them, how it actually has like an interesting ripple effect, and it's more pronounced. Because a lot of the metrics that are even applicable for certain populations are access measures. And to what you were trying to say, Michael, of like metrics that matter, the problem is in a lot of those sets, we don't have appropriate primary care metrics for the things that matter, like care coordination, like the things that aren't paid for in the widget model. So I don't in concept have a problem with these recommendations in concept. I think once they get operationalized, and particularly back to my original point, that's where actually the intent and why some payers are like, I'm not seeing it pencil out, is because of like, actually when you actually play it to the ground, that's where it starts to fall apart a little bit. So I agree with it overall, as long as recognizing that later on when we get to some of those sets, the metrics actually aren't around the angles that we want, and or are biased towards people who the denominator at a practice level is actually people who came in. And so then that makes the benchmarking hard.
Yeah, I appreciate that, Colleen. Thank you so much. And Carolyn's got a question, Michael, in the chat that I'm wondering if you could address.
I can't see the chat, so if you could share.
I'm going to tell you, if a practice is efficient, if a practice is efficient, then the 10% incentive would be based on a lower than normal total service payment. So that practice would get less than a practice who may not manage their patient populations as well. Or am I missing something? So if a practice, and Carolyn, maybe do you want to?
Yeah, I get it. I get it.
Okay.
I get the point.
Got it.
Yeah. So this isn't a formula, right? This is just setting a floor. So it's possible that a payer could have either modify this and say incented highly efficient practices, we're going to give you a bigger quality reward. Or we're going to give you a separate reward for being efficient in addition to our quality. So this is not intending to create a formula that says everybody gets 10% regardless of what their historical spend is.
Okay.
It's just saying nothing less than this, because if it's less than this, then it's de minimis and it doesn't provide a meaningful incentive or reward.
Carolyn, does that get at your question? Yes, thank you for clarifying. All right, let's keep going.
Okay, align quality metrics.
Sorry, hi, this
I
is
didn't
Dawn.
see
Sorry.
you. Sorry, didn't see you. Go ahead.
Something really quick, shouldn't take long. Can you remind me, Michael, if we also made it in there that to not have too much incentive tied to retrospective performance? Because I know I have recently encountered practices that have so much of their revenue not coming until the end of the year or after the year ends and tied up in metric performance, that it was very difficult for them to sort of make payroll every month. And so I remember we had that discussion, but I just wanted to make sure that there was something in here around. I mean, I know that we talked about timeliness, but I also feel like there's something there might be a ceiling we need in addition to a floor. I don't know what that would be, but something around that.
We did talk about this and we didn't reach consensus, which is why we have that second bullet about as proximate as possible. Because we did talk about having reward payments tied to delivery of specific services. So you get a bonus payment for each claim submitted related to delivery of a particular service. Okay, that would speed the delivery of the incentive payments, so they were happening and closer to real time. But there was an agreement within the group, and I think this was a little bit of a practice payer divide, if I can recall, on it. I think the point that you raise is a good one, that if the whole incentive payment is coming way after the performance period, that might create cash flow issues, but it also in some ways diminishes the strength of the performance incentive because you don't see it for so long. But this is just an area where I would say we didn't reach an accommodation. So we settled for that rather general language under the second bullet.
Thanks, Dawn. All right, onward.
Okay. Align quality metrics. I have a whopping 3 slides on this topic. So the recommendation is that there should be a subgroup that should be created to establish an aligned primary care measure set for the payment model that would have a balance of child, adolescent, and adult focused measures. It should be derived from the HPQMC's primary care focused measures or a successor body. And as some, if not all of you know, there might be a successor body. Recognizing that HPQMC measure set is not designed for primary care use, even though there are measures that are primary care focused. And so it would need to be modified to be applicable to primary care practices. You've heard some of Colleen's concerns about this. I will say, acknowledging Colleen's concerns, it is pretty common nationally to adopt health plan measures for use in primary care and I would say, broader system ACO incentive models. There was agreement that there should be flexibility for consideration of non-HPQMC primary care focused measures, especially given that measure set was not designed specifically for primary care. And so there might be some valuable primary care focused measures that could be supplemented. The work group members recommended some parameters to guide the work of the quality metrics subgroup to be. And I will note that there was not 100% agreement on the number and types of quality metrics among members of the group. So the workgroup members really wanted a very small measure set. And so there was agreement that and I would say the practice representatives in particular wanted to be very small. So they said that the total size shouldn't exceed 8 measures. I will note that that one or more payers expressed discomfort with the measure set being that small. There was agreement that the subgroup should establish a menu of primary care measures for use by practices and payers at their discretion, and then a smaller core set that should be used in all payer practice contracts. So this idea of a core set and a menu set is in use in other states. The really high priority measures are in the core set, and then the menu set allows for selection so that some of the measures can be customized to particular opportunities or profiles of individual practices. But because there's a finite menu, you're still getting some level of alignment for practices contracting with multiple payers. There was agreement the subgroup should establish different core measure sets for child and adolescent measures and for adult focused measures. So for example, blood pressure control is probably going to be in the adult focused measures core set, but not in the child and adolescent. And there was agreement that the subgroup should consider including one or more equity focused measures in the aligned measure set. There was agreement that the model should specify the payer contracts not include any quality incentive measures beyond those in the aligned primary care measure set. So all of this is pushing towards alignment across payers and reducing the universe of measures so that primary care practices can better focus their performance improvement activities in a finite set of topical areas rather than facing a very large number of non-aligned measures. Last set of recommendations on aligned quality measures. The subgroup should meet annually to make updates to the measure set to reflect measure steward specification changes, changes in national measure endorsement, or changes in the state level measures established by the HPQMC's successor, which might be the Health Equity Quality Metrics Committee. And then every third year, there should be a broader review of the measure set to look at what are opportunities for improvement in the state and across practices, and might there be any changing priorities in terms of area of focus. So annually, it's really just to make sure that the measure set is in sync with external references. And then every third year, there's a more comprehensive assessment. And those in 3 slides are the recommendations for aligned quality metrics.
Great, thanks, Michael. We'll go to Brian, then Scott.
Thank you. I don't recall, did we discuss what happens in clinics that have multiple payers? You know, it dawns on me that multiple payers could have multiple sets of 8, and so then the practice ends up having 24 measures, or and I don't think that's what we want.
Yeah, so I mean, you're right, there's some risk, Brian. The fact that there's going to be some core measures, so some number of the 8 are going to be core measures. So that means everyone would be using them. So let's imagine that there are 4 core measures. That means then there are 4 measures in play. Those 4 measures would be picked from the menu. We didn't talk about how big the menu is that they're picking from. The larger the menu, the higher the risk that the payers are not going to align on the 4. The smaller the menu, the more likely they're going to align. But inevitably, unless the contracting provider organization has got a lot of market clout, there probably are going to be some differences, but certainly way fewer than what there are today.
It still dawns on me, it might not be a bad idea to put in some kind of a, I don't know if it's a maximum number, but some kind of safeguard to ensure that we don't end up where we are now.
Oh, I think there's no way that you're going to wind up where you are now under this, at least this recommendation.
Sure, or
no way.
Close to it. I mean, I think the more, I think the goal of the discussion that we had was to minimize the burden on practices. And so the more we can do to make sure that that happens, the better.
And
Mhm.
Brian, if you have, do you have a specific suggestion, you can think about it and bring it to the work group or send it?
I mean, off the top of my head, it would be nice if there are practices that have multiple payers that the payers decide collaboratively what group of metrics they will decide on, and that they limit it to 8. Based on previous discussions about the power dynamic, I'm not certain anyone will agree to that, but I would just urge us to potentially pick a maximum number per practice that's allowable.
I am no expert here. There could be anti-competitive, antitrust stuff there, but I'm not an expert. I'm not giving legal advice, but I know that sometimes that can come up. So, but let's think about that and bring that back. Scott.
I really like Brian's comments and concerns. I agree with also yours, Diana, that there can be things that get in the way of good judgment, so to speak, from a legal perspective. My comment, if you could go back one slide, please, relates to the comment about one or more equity-based measures. And just to call out, I'll say my recommendation, which would be that you're going to learn a lot more and be able to practice, not practice, you're going to be able to run your practice better if you take single measures and differentiate them based on, I'll say, race and ethnicity or age or whatever you want to look at in terms of equity, because that's how you find disparities, as opposed to having one or more equity focused measures, which to me means find something that relates to a subset of your patients and look at that. That's a different thing. It's not a bad thing, but when you're looking for equity, you have to look for disparities. And to look for disparities, you want to take, I'll say, common things. Let's say like hypertension control, and then look at it across all of the demographics and look for where those disparities exist, and then address that in how you're providing care. So that's my recommendation.
Scott, I don't think the work group intended to exclude what you're talking about. I think this was intended to be general language because the group didn't really settle on exactly what the equity focus measures would be. So reducing a differential in, I don't know, postpartum care based on race, I see that as potentially fitting within this language here.
Great. Melissa.
Experiencing and agree with Scott Day. I would agree with that comment, but the specific comment that I would make is equity focused measures can be very complicated. And what we're seeing and what's being developed in equity focused measures is a lot of data outside of a general claims form. So it's hard to track and hard to manage. And we're seeing that with meaningful language access on the CCO side. So I would just hate for us to pin clinics into doing these equity focused measures if it's going to be problematic carrying it out until we can figure out a way to do this all better at state and federal level, how we track equity focused measures.
Thanks, Melissa. Anything else on this? Scott.
I just want to make sure that we don't throw out the baby with the bathwater. By that I mean doing nothing, in my opinion, is worse than I'll say doing something that's not ideal. And so we just pick out hypertension control again. We have that metric all we have to do is take it and break it up by demographics, and we learn something. We may learn that we're doing a great job, but we learned something by doing it. So I'm not asking for new metrics. I'm just saying with the metrics that we have, choose some of them and get the segregation of that data, so that you can learn something about disparities.
Thanks, Scott. Yeah, okay, let's just keep going. Michael, we're gonna get as far, I think we're pretty close. We need 5 minutes before the hour just to
Yep.
talk about one quick thing, but I think we're getting pretty close.
Yeah.
Go for it.
Okay, infrastructure payments. So this is the third aspect of the model. We talked about prospective service payments. We talked about the incentive payments. Now we're talking about infrastructure payments. So the recommendation is that all practices participating should receive an infrastructure base payment tied to PCPCH tier. And this would include payments to non-PCH practices that are actively seeking to obtain recognition, and then potentially additional payments as agreed upon by payer and practice for specific high-value services. And we have a long menu here. So I think this touches upon some of the services that some of you have expressed concern are not compensated today, but are what a PCPCH should be doing. And I'm not going to read through all of these, but these are ideas that we both brought to the work group and that were generated by the work group. So the ones that are under number 2 technically are not already paid for by the PCPCH program. And as we discuss this, the only model must have is number 1. The number 2 is at the discretion of payer and practice. Now, I do want to note that we are going to revisit integrated behavioral health services at our next meeting, which is one of the bullets there, the second to the bottom bullet. So we're going to talk about that again at the next meeting. So I don't think we've finalized that aspect of the model yet. Okay, a little bit more on infrastructure payments, and then we'll have discussion. For services that fall under the second category, and for which there are also PCPCH recognition standards, validation of the level of service should be tied to the corresponding PCPCH standard and measure. And should the primary care VBP model be adopted, OHA will commit to assembling and developing resources to help payers determine the appropriate value and levels of infrastructure payments, which is not a small undertaking, I'm going to note. But that would be a part and parcel of the work going forward if there is adoption of this model by payers and provider organizations. So I'm going to stop there. I'm going to go back to the prior slides. You're probably going to want to look at it.
So I have Melissa, Dawn, then Tim. So go ahead, Melissa. And there's some stuff in the chat too, but let's start with Melissa.
Thanks. So yes, I'm glad to see this, and sorry I'm late to the party, but for number 1, absolutely provider practices need help just getting to the PCPCH application, right? Because a lot of work has to happen prior to that and during that process. But can you tell me what the conversations were like? How do we measure when to start making those payments, and what was the conversation there?
I don't think we got that operational, Melissa, to be honest.
Okay, just a consideration.
Yeah, I think this is concept. So there'd have to be more work to make it operational.
Yeah, thank you.
Dawn. Did you?
Yes, under number 2, first bullet point, I believe that that bullet point needs to be removed. Those are services that happen within the PCPCH standards that are recognized with the infrastructure payment in number 1. In addition to that, if we are ever able to talk about risk adjusted payments and get any kind of social complexity in there, that should account for that. So I strongly recommend removing bullet point 1 from number 2.
The additional care management. That one?
Yes.
Okay. Thanks. Tim, were you trying to take yourself off mute? There you
Oh,
go.
no, I was just waiting.
Go for it.
So
You're-
I think my question may have already, Don, you may have pointed me to the point of the slide that answers my question, but in the entering, base payment model, number 1, way at the beginning, there's the discussion of risk adjusted advance payment and infrastructure payments. And I was just thinking about what is the way that we're going to do that risk adjustment, or that it's talked about. And it's probably that first bullet on number 2 versus the PCPCH tier level. I'm a little new to that concept. There's not a risk adjustment in there. When I looked at the
So
quick
we
reference,
have
that's
risk
just
adjustment as a separate design decision. So we're going to talk about that in a couple slides.
okay, great. That was my question, was just around that. Thanks.
Yeah, and let me clarify Don was talking about the additional care management, care coordination supports. This was supposed to be above and beyond what's in PCPCH. If there was a practice that had a patient panel profile that was sort of way above what the PCPCH was anticipating.
Got it. Yeah, in my very, very brief attempt to learn as much as I can about PCPCH, I didn't seem like there was risk adjustment inherent in the tiering. And so I just want to make sure I wasn't misunderstanding that.
Yep.
Okay, anybody else? Dawn, did you have something else?
Sorry, just this is not a hill I'm going to die on, but I just want to point out that there's potentially, while we're looking at all the design elements separately, when you look at them in combination, there's potentially 3 different places where risk is paid for and incorporated into that, right? So if we look at the infrastructure payments, if we look at PCPCH payments, if we look at risk adjusting, and so that's a reason why I get that there could be very extenuating circumstances, but a practice that is a tier 5 PCPCH with complex patients, they're going to be getting those tier 5 infrastructure payments in addition to having other payments be risk stratified that would hopefully incorporate some of that risk. So I just strongly think that that's not an element that needs a separate additional payment outside.
Yeah, thanks.
Okay. And I see Barbara's question in the chat. Michael, it says, would there be increased risk assumed for clinics that are migrant farm worker or healthcare for homeless designated?
Increased risk. I'm not sure in what sense.
Barbara, you want to chime in?
Sure. I think just thinking about, so I am at a healthcare for the homeless site, and just thinking about how, is there some room for like a designation of, hey, this practice already meets the criteria for being a healthcare for the homeless site. Therefore, perhaps their risk adjustment should be different compared to a different clinic that doesn't have that designation. I just want to throw that out there as a thought.
Yeah, or should be eligible for different types of infrastructure payments and other practices.
Right. Yeah, sure.
Right.
Okay.
Yeah. So, all right. So this, Barbara, bring that question back when we talk about risk adjustment.
I was just going to say, Michael, I think.
Okay, will do.
Anything else on this? All right. We just got a few more minutes. Go for it, Michael.
Okay. Yeah. We only have 5 minutes for risk adjustment. So risk adjustment is a super complicated topic. I just did a presentation yesterday for the CCOs on this. the recommendation from the work group is at a minimum, prospective primary care capitation payments and infrastructure payments should be addressed on age and sex. That's at a minimum. There are preliminary recommendations for clinical risk adjustment, which is making adjustments based on diagnoses associated with individual patients. And specifically, they are to use clinical risk adjustment when measuring a practice on total cost of care. That's what TCOC stands for. To not use it for prospective primary care capitation because there is no established tool for doing risk adjustment specifically for primary care, and instead rely on prior utilization for the practice. Acknowledging that prior utilization does not necessarily, I shouldn't say, prior utilization to some degree reflects need, but not completely. Because if you've got a patient population that is underserved, then prior utilization is not going to show that. But certainly it does to some degree reflect the burden of illness in the population. And then to use clinical risk adjustment for infrastructure payments, but with some limits, and parameters, these are not established here, including ensuring that there's a limited amount of variance based on risk scores. So I would say number 3 is not fully developed. And in fact, all of these recommendations are called preliminary because OHA is currently soliciting feedback from the work group on these recommendations, which were suggested during the last meeting. And so I would say these preliminary recommendations are subject to change.
So I think
Okay.
these are,
And then the work group will continue discussion of social risk adjustment at the next meeting. So Barbara, when you talked about risk adjustment, obviously people who are homeless, that's a big social risk that impacts their health status. And that conversation of social risk has not been concluded yet.
so here's what I'll say on this. As Michael said, this is really complicated and it's still preliminary. And so what I would suggest is that if you have interest in this topic, because we're not going to be able to give it the time it deserves right now, and these are only preliminary. If you have interest in this, please come to the next work group meeting to discuss it. Reach out to Summer and she can make sure that you know when. Summer, do we invite everybody to those? I can't remember, or just work group members?
We
just invite work group members, but
Okay.
I can add anybody.
Well, just so if you want to come to this conversation, let us know, because we will continue discussing this. And then Michael, I think you're just going to share with us the things that are still, oops, I thought there was.
Oh, sorry. Yeah. All right. So I can tell you without you seeing the slide in front of you. So what we didn't talk about were strategies to protect against unintended adverse consequences and how to promote health equity. Future work group topics are going to include payment for behavioral health integration, which I mentioned earlier, how to incorporate total cost of care. This is revisiting a prior recommendation. And as I just said, social risk adjustment. And then we're done. And we will have covered everything.
And
okay, we're not really done, but we're finished with the initial design work. Okay, and you have to celebrate all your accomplishments. And so we will at least have taken a large step forward.
Yeah, and let me also say that we're gonna take these comments back. This has been a really good conversation, and we're gonna take this, all these comments under advisement and try to figure out how do we address the questions and concerns folks have asked. And we will continue our conversations with folks because there's still more work to do. And come July, we will be looking to see if there's consensus, and we'll do our best to get to consensus. And if we can, that is amazing. And if we can't, that will be disappointing. And so we're really, what after we make additional adjustments, I just want to set this up for folks. We're going to be saying to you, are there things you really can't live with? And if you really can't live with them, we won't have consensus. We can have those who agree and those who don't agree. We're not there yet, but we will be there this summer. So we'll be doing more work. We'll be taking all of these, this under advisement. It's really, really good feedback. Appreciate, especially folks who haven't been on the work group, because you're just sort of, a lot of folks have been sort of living in this, living this, and this is hard. Last thing, Summer, do you want to show the slide? Do we have time for you to show those slides? So Summer, I'll turn it over to Summer and Chris.
Bringing them up. Can folks hear me?
Yes. And as you turn, I'll just give a quick, the bottom line here is that we want to share this with you. This is something the BBP Compact Work Group just discussed yesterday or 2 days ago.
Yeah, so these, as you see on your screen, these are the original BBP compact targets. You've all seen these before. I think we've also shared this as well, but wanted to bring it back to you. This is 2020 data. We should have 2021 data, hopefully in the next few weeks. But if we go back really quick, you can see that the 2021 goal target for percent of all payments that are in shared savings or higher is 35%. The bottom set of targets are specific to primary care practices and general acute care hospitals. Unfortunately, we don't have data broken out for those specific settings of care right now for 2020. We will for 2021, but it will be the first year that hospitals are required or payers are required to note when payment models include hospital. So that will probably not be the greatest data because it will be the first year. So just kind of noting that. But you see that 35% was for 2021 and 50 for 2022. There we go. And so here's the data from 2020. And you'll see in the red oval that all payers have met that first set of targets. They've met that in 2020. So we're hoping that that will be even more advanced in 2021 and 2022. But again, we don't have that data yet. And the BBP Compact Work Group felt like, given this this data and given COVID and the continuing impact of staffing across all settings of care, that they wanted to adjust the metrics or the targets rather, and then sort of move along and as we have more data. So you'll see this is the new targets. The original targets are in the parentheses below, and I'm just going to move us quickly. These are the new targets. So go back. So we reduced the work group reduced the targets for all payments by 10%, and then pushed the end date out to 2025. The original targets went to 2024, and then reduced the second set of targets for primary care services and hospitals that were to be free. Again, moving them out to a year, and you'll note that still not getting to 70%, recognizing that there's just significant changes there, particularly in the cost of care. So here's your the final revised targets. I just wanted you to see this. We'll be sharing this more broadly with the signatories to the BBP Compact, and more to come on this in the future. So I'm going to stop sharing.
And
Chris,
I was just thinking, just like explaining why I mean, it's kind of implied, but just to be responsive to some of the pushback that we've received to the kind of, because of what's happening with the system right now and workforce shortages, et cetera, that was, we've received feedback that it could be really challenging to meet some of these targets. And so just want to give more time to be successful.
Yeah, and still,
but still push for it. Yeah, keep going.
Exactly. Balancing the being sort of more realistic and also being aspirational.
Yeah.
And we're gonna wrap up, but I just addressed Colleen's question. So these slides this just happened 48 hours ago. And so hasn't been shared. We haven't even shared it with the voluntary compact signers yet. But given this group's intense involvement, we didn't want you all to find out through some back chat, and we knew we were gonna see you all today. So you will get this, just not for another week or so. All right, folks. Thank you, Michael. Thank you to the work group. Thanks to all of you for your questions, for being here. Let me say, we are going to try to just reiterate, we may be moving the meeting from July to June, number one. You will be hearing from us because we want to see how close we are to consensus. And our October meeting, you'll be getting a change in your calendar. We're going to extend the October meeting. We're going to make it in person, and we're going to make it some kind of retreat, like a 4-hour retreat. I wish I could tell you it would be in Hawaii, but it won't. But we'll do it at the Transformation Center, and we're going to try to get lunch there, and maybe also, some pineapple. How's that? To make us feel like we're in Hawaii. Okay. Thanks everybody so much for your time and energy and commitment. I know this is voluntary for all of you. It's really important work. And I hope you all have a great rest of your day. Thank you so much. Bye.